Welcome to my presentation. Welcome to my presentation of ACL Rehab. So we have Sarah, who's a 16-year-old netballer. She suffered an ACL and meniscus rupture on her left side. The mechanism of injury was a pivot to the right after landing on her left leg, and her left knee twisted and buckled inwards upon impact. She's now 12 weeks post-surgery. She had a semitendinosus graft. In her post-surgery rehab, she regained full knee range of motion, and she also did some quadriceps reactivation. Her previous injury history includes chronic ankle instability with lateral ankle sprains on both sides. So to interpret the results, in range of motion we've got limited dorsiflexion, particularly on both sides, which we would expect one with the injury, but also with a previous injury history of chronic ankle instability. This is demonstrated with knee to wall as well as goniometer measurements. We've got full knee range of motion, as we said before, or at least within 10% of the uninjured side, which is expected at this stage of rehab. We've got significant strength deficits, particularly in the quads between our left and right, which is definitely demonstrated with the 6RM, but also shown with manual muscle testing. Balance, we've got a comparative deficit on injured and uninjured side, which again we'd expect post-injury. We expect a strength deficit, but we'd also expect, as we can see here, deficits on both sides, particularly in the ankle, potentially due to issues at the ankle with chronic ankle instability, so both sides. On manual muscle testing is a subjective measure, but in saying that, seeing a clear deficit like we can see between injured and uninjured sides, particularly at the knee, would be consistent with expected findings of more objective tests like handheld dynamometry. So Sarah's goals, obviously, eventually she'd like to return to sport. We want to mitigate her injury risk or prevent injury as much as possible, but more so psychologically, we want to increase her movement confidence and competence and feel safe to do so. Activities of her sport including run, jump, cutting, bounding, and sprinting. So she wants to be able to do those safely as well. Practitioner goals in the first phase, we want to address range of motion deficits, strength and balance asymmetries and deficits as well. So specifically, we've got ankle dorsiflexion, range of motion, plantar flexion strength. We want to increase quadriceps strength, increase hamstring strength, increase lateral hip, glute med specifically strength, i.e. hip adduction strength. We want to reduce left to right balance asymmetries, improve balance, increase landing task confidence and competence, and prepare for return to training and return to play. So as the first session of the initial phase, there are a few inclusions. We've got quadriceps, hamstring, gluteal, and triceps surae loading exercises, preparation for plyometrics and landing tasks, which we'll use our term neuromuscular training, as well as unilateral or semi-unilateral exercises. It's important to note that exercise selections may not be exhausted of what could be prescribed in this phase. For example, given that a second or third strength-based rehab session may take place throughout the week, we would expect to see a wider variety of exercise to target the same tissues or qualities in slightly different ways, i.e. different variations of knee flexion and extension as an example. Supersets are used where possible to facilitate a greater in-session number of exercises to be prescribed without sacrificing adaptation. So as part of the warm-up for the first session, we have a bike erg for 5 minutes. This is going to increase core temperature as well as more localized knee tissue warm-up, so muscles, joints, ligaments, tendons, etc. Then we have a banded knee extension with a B stance glute bridge superset. This is to warm up and gradually expose the quads, glutes and hamstrings to mechanical stress, so i.e. graded exposure before getting into the more stressful stuff later on. Banded plantar flexion paired with knee to wall reps as well as ankle ABCs will provide the same graded and gradual exposure stimulus, but to the ankle musculature and other structures, and as well as potentially increase proprioceptive control of the ankle musculature. Seated bodyweight calf raises are added, one, to bias the soleus, because we know that if we keep the knee bent, we can bias the soleus and take away the bias of the gastroc. It'll also provide a helpful bridge gap exercise between banded plantar flexions and main session plantar flexion exercises, so like a standard standing calf raise. And into the main session, we have a single leg step downs are paired with triple extensions into drop landings. The step downs are prescribed to target quadricep and glute med strength with a targeted focus on eccentric control. This aligns with practitioner goals of targeting these areas, but also client goals where in the near future, the running and jumping tasks of the sport will require this musculature and the surrounding structures to be strong. As well, also, furthermore, eccentric and concentric training are both recommended during ACL rehab, so having the eccentric focus but a concentric phase is an appropriate selection. The triple extension drops to experience lower level eccentric training compared to something like a drop jump, and to introduce power training, plyometrics and landing tasks. It'll increase in confidence, and competence here is vital for the client and a key marker for progression into the next phase. Next phases indeed. Similar rationale can be applied to the prescription of single leg RDLs for glute med strengthening with the addition of unilateral hamstring strengthening, which will target both injured and uninjured sides separately, allowing for more targeted adaptation. This is an appropriate choice in this phase since the hamstring graft would leave more severe deficits and thus would need more graded and gradual exposure to load than the uninjured side. The step off into landing also provides plyometric and landing task preparation with the additional benefit of being unilateral. These exercises also have the benefit of training balance and neuromuscular control depending on the level of assistance used, particularly in the case of the RDL, which is also a key area of improvement. Balance and neuromuscular control, that is. 2 up, 1 down calf raises allow for gradual progression from bilateral to unilateral triceps surae strengthening. The stretch provided on the eccentric portion may also facilitate range of motion improvements in dorsiflexion. Furthermore, the strengthening of this musculature is also used as a treatment of the chronic ankle instability as a secondary condition. The lateral lunge variation allows for adduction and, if done correctly, abduction strengthening and neuromuscular strengthening, as well as introduction to movement and exercises in planes other than the sagittal. Intensity is kept relatively high when maintaining a lower absolute load. This maximizes the adaptation without over or prematurely exposing the tissues to stress. Rep ranges, and furthermore, rep ranges and rests are kept within those suitable for muscle strength and hypertrophy gains. So once we've completed the initial phase, we would like to move on to some more intermediate progressions. This will include the introduction of more advanced submaximal plyometrics, i.e. single and double leg hops and landings, as well as change of directions. We'll also start to introduce some barbell compound exercises like squat and hinge variations. This will allow us to increase relative and absolute load and helps the magnitude of stress, increasing our strength adaptations. We'd like to see some curved and swerved running. She would already be straight line running as part of her rehab, so we'd like to have some curve and swerving, but not quite change of direction at pace yet. Our progression criteria, it's important to note that we'd like an outcome-based approach rather than a timeline-based approach, but there's very little evidence for quantitative numbers that we need. So we rely on practitioner expertise for an observable increase in strength and movement quality, but almost more importantly is the psychological readiness of the client, which we will assess throughout the program as well. To elaborate on this, using psychological questionnaires along with constant check-ins with the clients will be crucial to ensure readiness for return to training and play. In stage 3 with advanced progressions, we'd be looking to add in Dual tasking, multi-directional and maximal output plyos, loaded jumps, Olympic lift variations. We'd go from strength maintenance to increasing power output. We'd go from moving into sports-related drills into sports-specific drills. Multi-directional change of direction, running and sprinting would be added in. Our progression criteria remains similar, with practitioner expertise relied upon for observable increases in strength and movement quality and psychological readiness.